Hi, Sevda Bağ from Bakırköy. I'm an expert specialized doctor. I will be talking about the antidepressant treatment during pregnancy. As stated by Mesut Bey, depression and its treatment, especially for female patients, is of great importance because among the psychiatric diseases, depression is the most frequent one and the prevalence is 16.2%. Therefore, in our polyclinics or in the inpatients, as the psychiatric disease, we see depression. The bipolar or the schizophrenia ratios are quite low. When we say depression, let's not only think about those come to our hospital. 16.2% is the one who seek for help in the clinicians. The ratio is normally higher than that. Most of us have depressed days. Sometimes we don't enjoy life. Sometimes we think about suicide. Depression is everywhere. Depression is in our relations with our spouse, in our office. In terms of depression, females are, more prone to depression, and a woman has a 10 to 25% risk of being diagnosed with a major depressive disorder in her lifetime. In developed countries, this ratio is less, and in the underdeveloped countries, this ratio is high, and there are many reasons underlying that. Being a woman is a problematic issue. The role of women in the society and the education level of women also changes. Therefore, the depression levels change. And the hormonal balances of the women are different after the adolescence, then the pregnancy, then the menopause. The imbalance in the hormones is starting to lead the woman and making her more prone to depression. Women, especially during their childbearing age, are at increased risk for first onset of major depression and have a lifetime rate of major depression 2.7 times greater than men. And 14 to 23% of pregnant women with experience depressive episodes. Starting from the adolescence period, women have a tendency to be more sensitive to depressive major disorders. Why are they more prone to depression during pregnancy? Pregnancy is a special period. Those who are mothers know it better than that. I have 2 kids, and pregnancy is a pathological situation because it's affecting the whole physiology and the pathology of one. It's okay to have a kid. It's nice to have a kid, but till that, it's a period of anxiety. Even if thinking about the sex of the baby you're gonna have is an anxiety process. Therefore, along with the increase in the beta HCG and again with the increase of the estrogen and the progesterone, and they're inhibiting some other hormones. Therefore, the pregnant women becomes more prone to psychiatric disorders. At the beginning of the study, it was thought that the pregnancy protects women from psychiatric disorders, but the latest studies show us that, the pregnancy is making the women more prone to depressive or the other psychiatric disorders. So, what are possible triggers of depression during pregnancy? First of all, as stated by all the women, and especially the pregnant women, relationship problems. It might be about the spouse, the husband or family, or mother-in-law, or the environment, or the office friends, colleagues. So they're all relationship problems. And one of the most important criteria is family or personal history of depression. Before getting pregnant, if a woman was diagnosed or treated for depression, it is also increasing the risk of having depression during the pregnancy. You know, the pregnancy might not be a desired one, or there might be some relationship problems, or just in the midst of all the problematic parts of her life, you know, she can get pregnant. And when there is a psychiatric family history of depression, then of course the woman is going to be more prone to the depression. Previous miscarriages. My colleagues will understand, female colleagues will understand, previous miscarriage is a serious source of anxiety. Not having an alive kid beforehand is putting pressure on the shoulders of the women on the new pregnancy period. Stressful life events. Of course, life goes on during pregnancy. All the stressful life events continue during pregnancy. And from time to time, you know, we might be protected by people around us just because we are pregnant, but other than that, our relationships continue. Therefore, the challenges continue. Health-related complications, namely the organic disorders of the women, some other diseases, existing diseases. It might make the pregnancy more difficult, and it might put the woman at risk. Therefore, thinking about them can get the lady depressed. History of abuse or trauma, you know, it might be sexual. And poor social support, you know, we do have a serious refugee problem in our country, and these women are escaping from war, and they're trying to establish new lives. So they are in another country, and they're also having the migration trauma. In such a situation, if they get pregnant, you know, and suffering from the pregnancy difficulties, you know, not having a kid that you don't know and which country that kid is gonna be, and being away from your own country, you know, this is creating a serious trauma. And poor social support in our country. From time to time, the social support is not at the desired level. It's not that strong and healthy, and social support is misinterpreted as giving support. It is protecting the pregnant. And the last but not least, financial difficulties. The fact that she's unemployed or she's not financially independent might create very problematic times. In the polyclinics, in your clinics, you might have seen, you know, many women having problems with his husband because she's not financially independent. She can only come and tell you her story because she can't get divorced because of the financial dependency on her husband. Therefore, these women are more prone to depression, especially during pregnancy. And untreated depression during pregnancy. Are we going to treat it or not during the pregnancy? Or at which scenario should we treat the pregnant with major depression? When a pregnant patient comes to you, you need to take her into consideration, because it was shown that only 10% of the pregnant women with depression come to the clinics. Therefore, we need to have a serious discussion with the patient, at least for 20 minutes, and in order to understand the patient, we need to be objective. We need to be understanding her experiences and what she's going through. Therefore, if the patient has a miscarriage in the past, and if baby is born at an early gestational age, early birth is triggered by the antidepressants. But when a correlation has been found between the antidepressant use and early birth, premature birth. But these patients are not the proper patient profile. The alcohol or drug abuses were not added up to that, or whether the drugs were used by the patient or not. So there are many variables. Even if the premature birth is triggered by the antidepressants, depression itself is a triggering element for the premature birth. Cortisol is being secreted. Transplacental passage lets cortisol to the baby, and GRH is a hormone which is secreted as a result of the increased cortisol level in the baby's blood, and it is related to the premature birth. Low birth weight. Let's imagine a depressed pregnant lady, she doesn't care about anything and she doesn't feed herself well. Therefore, low birth weight and the depression during pregnancy are correlated, and there are many studies in that regard proving so. Increased risk of preeclampsia and low neonatal Apgar scores and increased admissions to neonatal ICUs, postpartum depression, its most serious and suicidal ideas. When we see a depressive pregnant, we need to decide whether to treat her not by taking the postpartum period into consideration, because the postpartum depression is another risk. So we need to understand whether the patient has suicidal opinions or not. This is important. And in the untreated pregnant women in the postpartum period, the depressions in the postpartum, the suicide risk is higher, and also the seriousness level of the depression is higher, and also the treatment reactions are worse. So treatment. We diagnosed the depression in the patient and we decided to treat the patient. We do have a couple of approaches for treatment, one of which is the behavioral therapy, cognitive behavioral therapy. It is important for changing the wrong beliefs and also wrong behaviors. It's effective. And also support groups is another recommended treatment option. Yes, support groups are very common abroad. It's nice to have someone who is experiencing the same thing. Counseling, again, it's very common abroad but rare in Turkey. And apart from that, I didn't add something here. For the serious depression and the suicidal opinions, EKT, organic treatment, and also some light treatment. When I was assistant in 2003, for the depressive patient with fluorescent light, my professor was treating the patients with the fluorescent light, but abroad, the light treatment for pregnant women continue. But it might be bring the hypomania, therefore they stopped doing it in some countries, especially Scandinavian countries. I just read a study about that. And apart from it, omega fat acids. Omega fat acids can be useful for the depression, and also it's good for the babies. And acupuncture. They can be treated by acupuncture. All of them are valid for the medium level depressions, and we can decrease the trend of the disease. I will be talking about pharmacotherapy. It's not easy to decide upon continuing with the pharmacotherapy. Even if we diagnose the pregnant lady with a depression, are we gonna start with the pharmacotherapy or not? You know, we think that at least for 10 times. With a normal patient, unpregnant patient, you know, we are not going to think that much, because with the pregnant women, we are also considering the health level of the baby, because, you know, there are many studies showing us the negative effects of antidepressants on the baby. But when we look at the systematics of the studies, we see that they are missing, you know. Those women might be smoking or alcohol drinkers, or etc. There are many more variables which are missing in the studies conducted in the past. So we started interpreting the results of those studies differently just now. Therefore, we are making our interview with the patient, and afterwards, if we diagnose the patient with depression, then we are talking to the patient and we can have psychotherapy, you know, without pharmacotherapy. In the pharmacotherapy, we do have two groups: tricyclic antidepressants, the classical group, and SSRIs, of course. SSRIs are used most often, and they have been studied the most, and they do have less side effects. But there are 5 main items: congenital malformations, preterm birth and lower birth weight, and pulmonary hypertension, and newborn withdrawal, and also some long-term effects as well. You know, in the pharmacotherapy during pregnancy, there were some studies conducted on human and the SSRIs. Some congenital malformation risks were stated. Therefore, people were scared of using SSRIs for pregnant patients. However, in 2006, they made a cohort study, and association with congenital heart defects, especially septal defects, and in particular after exposure to paroxetine. And this is what we have right now. Paroxetine might have congenital heart defects. After that, paroxetine was classified in the D group by the FDA from C. Paroxetine is now D group. Yes, these are the results of the studies. Yet, paroxetine confers an increased risk of fetal malformations like the cardiac defects in particular, whereas fluoxetine, fluvoxamine, and sertraline, Stop-Lem, and the other ones don't seem to be involved in the risk of congenital abnormalities. In the recent studies, we see that there are some pregnant women using paroxetine during their pregnancy and having normal baby. And the antidepressant usage level among the pregnant women is around 30%, and among it there is paroxetine. But as a result of the cohort study conducted in Switzerland, FDA classified this as D. You know, we are trying to avoid paroxetine, but this risk is less with other drugs. Along with that, most of the studies carried out during the last 10 years agree that the teratogenic risk of these drugs overlaps with the risk in the general population, which is around 2 to 4%, which means that, you know, no depression, no antidepressants, you know, the fetus malformations risks are equal to the one with depression and using antidepressant. When you evaluate it according to the society, the antidepressants, especially the SSRIs, it's equal to the society as a whole. Newborns exposed to sertraline during the first trimester of pregnancy had a relative risk of anal atresia, which was 4 times higher than newborns exposed to other antidepressants. However, anal atresia is a very rare congenital malformation, whereas the risk for an infant exposed to sertraline is 0.2%. Along with that, anal atresia is a very rare congenital malformation. As I stated earlier, it is 0.2% risk. Okay, persistent pulmonary hypertension. This is important. 10 to 20% of the affected babies cannot survive. Just after the birth, intubation and mechanic ventilation might be required in the respiration problems. The SSRIs in the second trimester might increase the risk of pulmonary hypertension. But as I stated earlier, none of the studies have used the same method, because in all cohort study or in all the studies they used different methods. Therefore, it's not possible to say that it is triggering that 100%. They're only working on the case studies, and there are some limitations about the studies regarding the antidepressant usage of the pregnant women, because you can't test it on human beings. It's not appropriate to have such a trial. You can't risk that. So all of these studies are retrovert studies. We are looking at the mothers of the already born babies. Therefore, the results are affected by many variables, as methods are different. So the result might not be 100% correct. Pulmonary hypertension. It's increased pulmonary vascular resistance. And serotonin has vasoconstrictive characteristics, therefore nitric oxide inhibition. And in the second trimester of the pregnancy, if the lady gets SSRI, pulmonary hypertension risk is 0.1% to 0.6%. And newborn withdrawal syndrome, 48 hours later of the birth, the respiration problems, jitteriness type seizure, irritability, change in the sleep pattern, tremors. It's not like the pulmonary hypertension. Newborn withdrawal syndrome continues for about a week, and there is no risk of death like the pulmonary hypertension. And when we look at the long-term effects, this was not understood that well, but there might be some behavior problems, and especially with the ADHD kids. The mothers during pregnancy might be using antidepressants. They looked at the correlation. They say that serotonin is very effective in the formation of neural crystalline cells. Therefore, you're giving them SSRIs, and SSRIs are passed to the kid, and each SSRI is passing to the baby. Only sertraline cannot pass through. Lefloxetine is said to be transferred to the baby very seriously, and neural crest cells migration can be stopped, and afterwards, after the birth, there might be some behavior problems, and autistic spectrum disorders might happen. Some studies allege that, but of course the results are not certain. There are some studies alleging that it might be effective on the intelligence level of the kid, but up to the age of 6, but then they catch up with the normal intelligence levels. In the antenatal depression, these are the common medications that we use. fluoxetine, sertraline, citalopram, and escitalopram. And among these four, the most recommended is the sertraline and citalopram. In the studies, congenital malformation risk were shown to be less with these two medications, and it is transferred less to the baby. Sertraline and citalopram, they're more trusted, and fluoxetine, because there is some effect, but escitalopram, if you don't have anything in your hand, it might also be recommended. Venlafaxine, duloxetine, and mirtazapine, 30 milligram is recommended. Bupropion, if there is a risk of epileptic seizure, up to 3 milligram. Tricyclic antidepressants, dopamine and trazodone might be used for sleep, because the pregnant woman needs to sleep. We know that sleep is very important during depression. If the pregnant cannot sleep well, then the depression can be even worse, can get even worse. Please wrap up. SSRI used during pregnancy. We defined it, we discussed it. Then we are looking at the profit and loss ratio. Then we will discuss it. And we are doing that with the patient and also the relatives of the patient. And this is recommended only in the cases of moderate to severe depression. We can treat these patients with the psychotherapy, but this is one of the options we have in our hands as a treatment besides the psychotherapy. And we need to use the minimum effective dosage needed to maintain psychiatric stability and normal function. We need to start with the minimum dosage. Polypharmacy is very important. And if there is a history of recurrent episodes of depression in women, it might relapse during pregnancy. And paroxetine use among pregnant women and women planning pregnancy should absolutely be avoided. Which antidepressant then? It should be individualized approach, and SSRIs prefer to tricyclic antidepressants or SNRIs, and we need to avoid paroxetine, and sertraline seems to be the best antidepressant choice with the minimum dosage. Thank you very much.